Well, good afternoon, everybody. My name is Dan Polsky, and as co-chair of this committee, I'd like to welcome everyone to the first meeting of the Committee on the Review of Federal Policies that Contribute to Racial and Ethnic Health Inequities of the National Academies of Sciences, Engineering, and Medicine. And this study is sponsored by the Office of Minority Health. I'm joined by the committee members who are also participating virtually. In a minute, I'm going to ask them to introduce themselves. Before we proceed, however, I want to note that this is an open, on-the-record session. Interested individuals have been invited to attend as observers via video conference. I'd also like to remind everyone that this is an information gathering session. That is, the committee is just beginning the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. So I ask everyone to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or the National Academies of Sciences, Engineering, and Medicine. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. The committee's report is expected to be released in the spring of 2023. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee. This is the first information gathering session of the committee, which will include a presentation from the project sponsor. The date for the next information gathering meeting will be identified soon. We'll include presentations from invited speakers and a public comment session. Meeting information will be posted on the project website. In addition to the remarks we will hear today, the committee has reviewed information relevant to its charge and will continue to gather additional information over the course of the study. The sponsor's comments today will be followed by a question and answer period between the sponsor and committee members that will focus on clarification of the statement of task. And if time permits, questions from attendees related to the statement of task for the sponsor will be asked. Please note that this meeting is being recorded. So now I'd like to ask committee members to briefly introduce themselves, giving their name and current affiliation. And just keep in mind that brief bios of all committee members are available online. So I'll start out. I'm Dan Polsky, professor of health policy and economics at Johns Hopkins University. And next, I'm going to turn over to my co-chair, Sheila Burke.
Thank you, Dan. I'm Sheila Burke, and I'm pleased to be the co-chair along with Dan of the panel. I am currently on the faculty of the John F. Kennedy School of Government at Harvard University and chair of the Public Policy Unit at Baker Donaldson.
Medina Aguinar.
Hi, everyone. Good afternoon. I'm Medina Aguinar. I am an assistant professor in the Department of Behavioral and Social Sciences at the Brown University School of Public Health.
Camille Bissett.
Hi, good afternoon, everybody. I'm Camille Bissett. I'm a senior fellow at the Brookings Institution and the director of the Race, Prosperity, and Inclusion Initiative over there. Thank you.
Juliet Choi.
Hello, welcome everyone. Juliet Choi, President and CEO of the Asian and Pacific Islander American Health Forum.
Juan de Lara.
Hello, everyone. My name is Juan de Lara. I am the director of the Center on Latinx and Latin American Studies and an associate professor in the Department of American Studies and Ethnicity at the University of Southern California.
Thank you. Megan Douglas.
Greetings, everyone. Megan Douglas. I am an assistant professor in the Department of Community Health and Preventive Medicine and the Director of Research and Policy in the National Center for Primary Care, all at Morehouse School of Medicine.
Abigail Echo Hawk. We'll come back to Abigail. Hedy Lee.
Hello, everyone. My name is Hattie Lee, and I'm a professor of sociology at Washington University in St. Louis.
Thank you. Margaret Moss.
Sorry. Hello, everyone. I'm Margaret Moss, and I am calling to you from the traditional lands of the Musqueam people. I am an enrolled member of the 3 affiliated tribes of North Dakota. I'm at University of British Columbia right now, where I'm their interim associate vice president of equity and inclusion, but I am on faculty in nursing. Thank you.
Karthik Ramakrishnan.
Hi, everybody. I'm Karthik Ramakrishnan. I'm a professor of public policy at the University of California, Riverside, also the founder of AAPI Data, and I'm also the executive director of the California 100 Initiative.
Lisa Servan.
There, I'm Lisa Servan. I'm sorry, it's saying that I can't start my video because the host has stopped it, but I'm here, everyone. I'm Lisa Servan. I'm professor and chair at the University of Pennsylvania. I chair the Department of City and Regional Planning at the Weitzman School of Design at Penn. Welcome, everyone.
Vivian Shandas. Vivek Shandas, I'm sorry.
Hello, everybody. Vivek Shandas. I'm a professor of geography and climate adaptation at Portland State University.
Thank you. And Melissa Simon.
Hi, everyone. I'm Melissa. I'm OBGYN by training at Northwestern in Chicago, and I'm also the director of the Center for Health Equity Transformation.
Did I miss any of our committee members who are here today?
Hi, I'm Diane Whitmore-Shansabach. I'm the Margaret Walker Alexander Professor at Northwestern University, where I'm also the director of the Institute for Policy Research. And unfortunately, I can also not start my video.
Hi, Dan. Sorry, I missed you. Anyone else? A couple of our committee members, Thomas Dobbs and Mario Cardona, were unable to join us today, but just calling out their names to round out our amazing committee here. So next, I'd like to introduce Rear Admiral Felicia Collins, Deputy Assistant Secretary for Minority Health, Director of the Office of Minority Health, Department of Health and Human Services. Rear Admiral Collins will provide background information on the study and present the committee with its statement of task, which will be followed by a Q&A with the committee. I'll turn it over to you.
Well, hello, everyone. It's really a pleasure to join you today. As was noted, my name is Rear Admiral Felicia Collins, and I have the honor of serving as the Deputy Assistant Secretary for Minority Health and the Director of the Office of Minority Health within the Office of the Secretary of the U.S. Department of Health and Human Services. In brief, I typically describe myself as a pediatrician by training, but a public health practitioner at heart. And I've spent my career as a United States Public Health Service officer focused on addressing health disparities experienced by racial and ethnic minority populations, as well as other vulnerable and underserved populations. I am so very delighted that we have such an esteemed group of individuals that have been convened in this effort to review federal policies that contribute to racial and ethnic health inequities. Your collective expertise is vast, as you've already demonstrated, but allow me just to summarize it again for others. Your expertise involves nursing, medicine, public health, population health, public policy and administration, epidemiology, sociology, urban planning, economics, early care and education, civil rights, law, and more. So thank you so very much for agreeing to undertake this very important effort. Next slide, please. So my presentation today has 5 major sections. And so during our time today, I want to review the Congressional Appropriations report language that has resulted in the formation of this committee. I'd like to provide a brief overview of the Office of Minority Health. I want to review some key definitions related to the Congressional Appropriations report language. I want to review some considerations for you, the committee, as part of your statement of task. And I will end by providing some additional environmental context. Next slide. So this committee is being convened in response to Congressional Appropriations report language for the Office of Minority Health. The report called for the Office of Minority Health to engage the National Academies of Sciences, Engineering, and Medicine to review current federal policies that contribute to health inequities, including those policies that impact the social determinants of health, to provide analysis and potential solutions that are both evidence-based and nonpartisan, to identify the most effective or promising strategies to advance racial and ethnic health equity, and to include the following populations in the analysis: Black or African American, Hispanic or Latino, American Indian, Alaska Native, Asian American, Native Hawaiian, and Pacific Islander. So that is the task that's been outlined by Congress. But I want to back up a bit and provide some background information that I trust will be helpful to you as committee members as you embark upon this task, and to those that are joining today from the public. Next slide, please. So let's start with a super brief overview of the Office of Minority Health, or OMH. For those of you who are not familiar with OMH, our mission is to improve the health of racial and ethnic minority populations through the development of health policies and programs that help to eliminate health disparities. Now, we have a variety of functions related to partnerships and data, information dissemination, demonstrations and evaluations, all of which are ultimately intended to support us in promoting policies, programs, or practices. We actually align these functions together in a unifying goal across the office that I fondly call SQPQ. And that stands for the success, sustainability, and spread of health disparity reducing or health equity promoting policies, programs, and practices. So even with this very high level overview, you can already see an alignment of the Office of Minority Health's focus on policies that reduce health disparities and the congressional request for a review of federal policies that contribute to health inequities. Next slide, please. Now, I often describe this SQPQ concept as a relay race, with identifying those successful policies, programs, and practices as the first leg of the race. But we clearly can't stop there. In order to eliminate health disparities and move towards health equity, we have to support efforts that sustain successful policies, programs, and practices. And we have to promote their spread or scalability to other communities, to other states, and to other regions. Next slide. So thus far, I've used the terms health inequities and health equity, social determinants of health, and health disparities. And I believe that these terms are likely very well known by the committee members. But since this meeting is open to the public, I think it's important that I ensure that we all are familiar with some very basic definitions that show how these terms relate to one another. And so my first definition is health equity, which is defined as the attainment of the highest level of health for all people. Now, this slide depicts the difference between equality and equity, which often is a point of confusion. The figure on the left shows 3 individuals that have the same size block to stand upon. So there's equality in that sense, but only one individual can reach the prize or the opportunity. On the other hand, the figure on the right depicts equity, in which the concept of fairness has been applied to the block upon which they stand in order to ensure that all 3 have access to the same opportunity, or health equity, for the purposes of our discussion. So in very simple terms, when fairness for accessing opportunities is lacking, health inequities will exist. Next slide, please. And one of the ways we know that health inequities exist is when we see differences in health outcomes among different populations, or health disparities. A health disparity is when a population has a level of disease or health condition that is disproportionate to their representation in the overall population. This slide represents a visual representation of health disparities in the area of HIV. noting that African Americans make up 13% of the US population, but represent over 40% of all new HIV cases. Next slide. Now, we know that health disparities related to HIV and countless other areas existed before COVID-19 came onto the scene. However, for many, the concept of health disparities was more broadly understood across the nation, and there was a heightened significance in the context of the pandemic. So this slide provides a high-level overview of racial and ethnic COVID-19 health disparities within the US back in March of 2021. And it's unfortunate to say that the recent data are not much better. The bottom line is this: racial and ethnic minority and American Indian and Alaska Native communities have disproportionately higher rates of COVID-19 cases, hospitalizations, and deaths compared to non-Hispanic whites, even after adjustment for age. And in this case, the disparities are greatest in the area of COVID-19 related hospitalizations. Next slide. Now, there are many reasons why we as a nation should work to eliminate health disparities. And I've listed just a few here, and the list could easily be much longer. For some, addressing health disparities is an issue of human rights, as they believe that everyone has the right to access affordable, quality health care. For others, addressing health disparities is an issue of social justice, as they believe that social inequities are the drivers of health disparities. And for those who maybe don't ascribe to a human rights or social justice reason, there's absolutely an economic case to be made, which I think is quite compelling. The Kaiser Family Foundation has reported that disparities result in over $90 billion, and that's B with a B, in excess medical costs, with additional tens of billions of dollars lost in productivity and premature deaths. So given these three reasons alone, the work of this committee to examine the issue of health inequities, which are manifestations of health disparities, is critically important. So if I go back to those key definitions, if health equity is our goal, that is the attainment of the highest level of health for all people, and the presence of health disparities is a sign of health inequities, how do these concepts connect to the thought of social determinants of health? Next slide. The connection in my mind is that health inequities are driven by social determinants of health. Now, there are a variety of frameworks for describing social determinants of health. I tend to use the framework provided by Healthy People 2030, which is a national initiative led by the Office of the Assistant Secretary for Health's Office of Disease Prevention and Health Promotion. As you likely know, the Healthy People Initiative provides science-based 10-year national objectives for improving health across the nation. Healthy People defines social determinants of health as the conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Next slide. Healthy People drills down further to identify 5 key areas of social determinants of health. And when we're trying to improve health outcomes, we often think of interventions involved with the healthcare and quality category. And that clearly is one of the social determinants of health. However, in my mind, the advantage of having a social determinants of health perspective is that we see that there are multiple other areas that drive health inequities and health disparities. And thus these areas require interventions also. These other areas include economic stability, for example, employment and housing stability, education, for example, language and literacy, social and community context, for example, civic and social participation and experiences of discrimination and racism, and neighborhood and built environment, which includes housing quality and exposure to pollutants in the environment. I want to pause here and note that there is a difference in addressing social determinants of health and addressing social needs of individuals on a one-by-one basis. Addressing individual social needs is very important, and we need to do that. But addressing social determinants of health differs, as it requires thinking about social impacts at a population level, and it considers systemic factors in effect. Next slide. So coming back to the task of the committee, I offer the following considerations. Based on the relationship between health inequities and social determinants of health, and how social determinants of health are drivers of health inequities, I recommend that you review federal policies that contribute to health inequities using the organizational framework of the Healthy People 2030 5 key social determinant of health areas, as listed on the slide. Next slide. I also will offer the following additional considerations. While the Department of Health and Human Services is sponsoring this committee report, I believe that each social determinant of health should have a similar level of attention and effort without a predominant focus on the healthcare and quality area, as that is consistent with the concept of a multifactorial social determinants of health framework. That will support the Department of Health and Human Services thinking broadly about our potential policy interventions, and it will support me and others in the department in engaging our colleagues and partners across the US government to use the report as a tool within their areas of authority. In my mind, having no policy in an area is in fact a policy statement that could be associated with health inequities, and thus should be included in the committee's analysis and recommendations when appropriate. When considering each social determinant of health area, I recommend that the committee also consider the infrastructure needs, such as financial investments, data, workforce capacity, community engagement, and systems for oversight and accountability. I recommend that the committee's analysis and recommendations provide a roadmap for action, measuring progress and accountability. To me, that translates into a depth of recommendations and strategies over quality of air, or quantity, I should say. Let me say that again. That translates into a depth of the recommendations and strategies over the quantity of policy areas that are analyzed. Now, the committee undoubtedly will identify issues that can't be realistically addressed all at once. So having the committee's sense of prioritization of promising strategies within and across social determinants of health areas will be extremely important. And I envision opportunities for the committee to highlight intersectionality when applicable to specific policies associated with health inequities, with intersectionality being defined as the social identities that work on multiple levels and result in unique experiences, opportunities, and barriers for each person, such as race, ethnicity, socioeconomic status, gender, gender identity, sexual orientation, age, ability, immigration or refugee status, language, and education. Next slide. Now, the next several slides provide some environmental context for the committee's review of federal policies impacting health equities. If you were to just do a quick Google search, you would see that there are many organizations that are reporting examples of federal policy areas that are associated with health inequities. And I've just highlighted a few on this slide that include preventive health or mental health service access, early childhood development and education, housing, safety and affordability, access to healthy foods, broadband access, and the child tax credit. And as we see, each of these examples can be mapped to at least one of the social determinant of health key areas defined by Healthy People 2030. Next slide. In addition to requesting a report from the National Academies, Congress has also directly reported on the impact of federal policies on inequities. In January of 2021, the Congressional House Committee on Ways and Means released this report describing the relationship between health and social well-being and economic policies. Of note, the report highlights how policy areas such as economics, social welfare, education, and housing and community development can have an intertwined impact on health and well-being. Next slide. Back in January of 2021, the president issued an executive order on advancing racial equity and support for underserved communities through the federal government. One statement in the executive order, which is noted at the bottom of this slide, charges executive departments and agencies to recognize and work to redress inequities in their policies and programs that serve as barriers to equal opportunity. Next slide. And before I close, I would be very remiss if I didn't note at least a few of the Department of Health and Human Services efforts in this space. And so this is just a very small sample of work depicted on this slide, ranging from specific policy areas of postpartum coverage of healthcare services and the earned income tax credit policy to broader areas of the inequities in our public health systems and in biomedical research. Next slide. So going back to that earlier analogy of a relay race, I see the Office of Minority Health and the federal government more broadly joined with this National Academies Committee in a health equity relay race. The committee has the first leg of the race to identify federal policies contributing to health inequities and to provide solutions and strategies for addressing these inequities. That will then position the federal government to pick up the baton, to implement identified solutions and strategies, and to measure implementation impact. So with that, I want to thank you again for your efforts and for joining with us in the pursuit of the highest level of health for all people. Next slide. There are multiple ways to connect with the Office of Minority Health, and I invite committee members and others from the public to stay connected via one or more of our communication platforms that are listed here. Next slide. Thank you very much.
Well, thank you. That was just tremendous, and we really appreciate you walking us through all that and providing that context and background and guidance. And so, you know, I believe I speak for everyone on the committee when I say how excited and eager we are to continue in this important work. So thank you very much for your comments. And with that, we'll turn to the next phase of this this hour together and reach out for comments or questions. You can, let's see, so raise your hand on Zoom. If you have any questions on the committee, and I'll call on you. Use a hand function there. I see Camille. You can go first. Thank you.
Rear Admiral Collins, thank you so much for your excellent presentation and for clarifying our task. I have a question around the scope of work for the committee in terms of providing solutions. So you had mentioned that you're looking for a roadmap. You talked about the lack of current policies, and you talked about our role as providing solutions. So within that, I wanted to understand whether providing solutions includes recommending new policies. Thank you.
So thank you for that question. Absolutely, because in my mind, as you are doing your work and you are delving into those social determinants of health areas, I do think you may find in some cases there's a lack of policy. And so lack of policies in my mind is a policy statement. So I would absolutely want you all to dig into that and note that, because I do see, again, this report is broader than the Office of Minority Health. The impact is broader than the authorities that I have. And this could absolutely be something that Congress would use to think about new statutes and other parts of the federal government, I hope will take up. That's going to be my charge. That's my leg of the race once you finish, to encourage, motivate, and to get all of government involved in these efforts.
Great, thank you so much.
Others from the committee? I will take the prerogative and pose a question. In your additional considerations, you talk about a roadmap for action, measuring progress and accountability. Can you expand on that just a little bit on that piece of our charge?
So as we're all aware, there's we often in a variety of settings can have great strategic plans and actions set forth. And the more concrete sometimes the actions are, the more likely that they can actually be carried out. And my goal is absolutely for this to be an action-oriented process. I don't want this to be a report that sits on somebody's shelf and that it's a checkbox for the Office of Minority Health. And sometimes we in our best efforts to implement new policies, programs, or practices, if we're not thinking ahead of time in terms of what does success look like, we oftentimes don't have a good way of knowing if we're actually moving in the right direction with our interventions or not. And so in my mind, data measurement evaluation is a really important part of the implementation aspect of this, and one in which your efforts as committee members can help can help us when we pick up the baton, the federal government, ensure that as we're moving forward, we're actually moving in the right direction.
Thank you. I assure you this committee is very vocal. We don't see, okay, Medina.
Hello, and thank you so much for your presentation today. It was wonderful to hear about your framework and your vision for this work. One question that I have is around thinking about the role of historical factors in shaping the social determinants of health that we have today. And so one thing that I would love to understand is the extent to which our task includes addressing either through new policies, like you suggested earlier, some of these historical determinants of the social determinants of health inequities today. Thank you.
So I think you are trying to, or getting at the issue of root causes, right? So that the social determinants of health in some ways may be symptoms and not the root cause. And I would welcome digging into what some of those root causes are if you're able, because as we know, you can always treat the symptom. I mean, as a clinician, I can treat symptoms, but if I don't treat your root cause, odds are that asthmatic patient, for example, is going to be right back in front of me within a week or two. So appreciate that comment and can see the importance of thinking about root causes.
Thank you. Next, Karthik.
Thank you. My question is about the interface between federal agencies and state agencies. Often when it comes to many of these policies, when it comes to implementation, from direct health policies like Medicaid to many other policies related to housing, transportation, and the like, what matter, often there's co-investment at the state and local level. And certainly when it comes to implementation, these are very important actors. So I'm curious, even with the charge, thinking about federal agencies, how much you might welcome or not welcome the attention to this federalism framework and the extent to which state and local agencies are important players as well.
So I actually thought about that as I was preparing, and then redirected myself to the language in the appropriations report so that I didn't at the outset maybe expand the box too big. But your point is very well taken. And we saw that absolutely in the case of COVID. A lot of what we were trying to do with regard to data collection was firmly dependent on what was happening at the state and local level. And if they weren't able to collect the data, then we weren't able to report it. So with that point, very well taken. And so the question, would I welcome that? I absolutely would welcome understanding or your thoughts and insights related to how the federal government can utilize policies and can support states in their efforts, because it is we're really all in this together.
Thank you.
Megan.
I was going to also ask about the implementation and state level role there. And I guess I'll just build off of the your response there in thinking about the federal government's authority to expand on some of the implementation, or I guess how should we be thinking about what the federal government, Congress, or executive branch authority is and how we're assessing these policies?
I would, in my mind, I would put some of that, the question of authorities, to me, that's a type of policy, whether it's statute or it's more granular once it comes to the various departments to implement. And it'll be interesting. I will be very interested to see if you all in your work identify that there are just statutory barriers in these areas, and that there is a role for Congress, because clearly, you know, within the United States government agencies, we can do what we have authority to do. We cannot go outside of that authority. And if the root causes are somewhere else, so if it's a statute issue, that information will be very helpful to us. And we will be, and I know that our colleagues on the Hill are going to be very interested in the report and watching this, and so would welcome those types of comments.
Thank you. Sheila.
I wanted to, thank you as well for your presentation, which was very helpful to us. I mean, one of our challenges was figuring out the scale and scope. One could imagine the breadth of policies across all the agencies, from Treasury to HHS. And so having a sense of how you think about that was very helpful. But I wanted to go back to Karthik's point and really touching on Megan's as well. You note that there are statutory provisions that could be re-examined, which would call on Congress to do so. But one of the examples Karthik used was Medicaid. Perfect example of a program that is federally and state controlled and shared. Whether you have thought about or whether or not you imagine us revisiting what the fundamental statutory policy is on some of these programs. In the case of Medicaid, it is a program that is got minimum requirements based at the federal level, but huge flexibility for the states. There are similar kinds of situations, whether it's the food stamp program or whatever, WIC, whatever it happens to be. Do you imagine within the purview of our work to re-examine what the fundamental statutory provisions are that divide up the responsibilities between the flexibility provided to the states as well as the statutory requirements at the federal level?
I do, if you all are come to the conclusion that that's the source of the inequity. Like, I think the concept of what the root cause is a good one to think about, because again, if we can play around the edges, but if the root causes require a reimagining of federal programs at their core, I think that type of information is critical so that we can really make the difference and achieve the equities that we're seeking to achieve.
Thank you.
Juliet, you're up next.
Great. Thank you so much. Again, wonderful presentation, and I'm really appreciating all of these questions that our fellow committee members are sharing. So I am trying to tie this broad scope and task at hand, combined with really appreciated how you framed and you're asking us to create an actionable roadmap. So it's going broad and then trying to ground it in actionable, foreseeable efforts. So focusing a little bit more at the federal government level, when we do examine whether there are policy gaps, improvements, again, trying to tie it to what's more actionable, do you envision us trying to do a broad scan across all of federal government when we're thinking about the root causes and social determinants of health? Or is there a practical sense that perhaps we should weigh our outlook a little bit more within the purview of HHS as the lead department? Earlier you had mentioned, for example, even if it's Medicaid, and I think a lot of us are also stating that immigration status is certainly a social determinant of health. To get to be able to address some of the issues of access to care, for example, would require some kind of, at least at a minimum, interagency, a willingness to address some of the policy issues, either from a regulatory standpoint or administrative standpoint, that could include agencies like HHS, agriculture, Homeland Security, and more. So again, if you could just share some of your thoughts on how much we should weigh a broad interagency approach or lean a little bit more towards HHS for the purpose of that actionable roadmap. Thank you.
So appreciate the question. I would offer that the starting point not be a particular department or set of departments, but the starting point be those 5 social determinants of health areas. And in thinking about them, what are the policy issues that may, and then let that direct you to what part of US government may be involved. I absolutely am not of the mindset that this is a report, again, where it's going to be primarily for HHS and we're going to do our part, because we already know that the issues, as you mentioned, immigration being a great example, the issues go beyond HHS. The other thing I will share is that we are fortunate that we have had in the past and continue to have many opportunities to collaborate with other parts of the department, or other parts of the US government, I should say. And one example of that, we actually host a group called the IHEC, the Interdepartmental Health Equity Collaborative, which includes 9 different departments, 11 parts of HHS. So we have infrastructure by which we can share recommendations, tools, work together across the US government. And that's just one example. So I would absolutely encourage you to think absolutely beyond HHS, because I do think that's some of that may be part of the root cause, that we think about what's happening in each department and we don't see how these issues are intertwined across our agencies.
Thank you. Margaret.
Sure, thank you. I appreciate my committee members bringing up some of these topics because it's making me think. So I have 3, they're short for you, and I really appreciate your presentation as well, because it clarified a lot of things. However, it did give me a couple of questions. So one of them is, I appreciate the members bringing up the historical and root causes, because specifically for the population that I most look at, the historical aspects of American Indian health are deep. I was telling some of the members that federal Indian law is based on laws from the Marshall Trilogy of the 1800s, and causing many of the problems today. So with that, I'd like to say that, I understand this question of how is the interplay between federal and state. And I would like to submit that there's also a 3rd political governmental body, which is tribal governments. And that throws in another wrench when we're talking about this population. So I just want to make sure that it's trying to listen to your answer of how do we look at state and federal interacting. And then there's this 3rd, and tribal governments interact with states, with federal and so forth. So just bringing that forward. And then when you're using the Healthy People 2030 for the social determinants of health, again, sorry, I have a focus on this population. I know that there aren't things there that would be apropos for this population. So I'm wondering if we are able to slide a little here or there, or add the thing. For instance, safety is huge with the murdered and missing Indigenous women and so forth. The prison pipeline by population, there's more American Indians in federal prison than any other group, this sort of thing, and whole identity problem misidentification in state records and so forth that are then reported by federal government. Anyway, there's things there that weren't necessarily listed. I don't know if that was meant to be a comprehensive list of the social determinants of health. And then lastly, with this group, because of the historical reasons that I said, I usually go one level below, even looking at structural determinants of health, which is the policies, funding, and so forth. And that would go above, as the last discussion was, HHS, such as the constant underfunding by Congress of the Indian Health Service, and maybe the need to elevate the director into an assistant secretary under health, and things like this. So that's outside of HHS. So just some clarity on, is it okay to look at those things? And that's my last. Thank you.
So you mentioned some points that normally I would have addressed differently. And so I appreciate the opportunity to clarify. So in other settings, what I frequently will say or try to say, usually when I talk about state, I usually say states, territories, and tribes. And so absolutely, within the Office of Minority, that is our structure and framework. And we work very frequently with tribal nations and understand and see the importance of that as we work to help to advance health equity within American Indian, Alaska Native populations. So would absolutely, if there is conversation, discussion about states, it should be including tribes and territories also. For the thinking about areas that don't quite fit those social determinants of health buckets, what I did was I listed just some examples. So that was not inclusive of everything. And it would be, I would offer that just in my thinking about other things, usually I can find a spot where anything fits. And so when you talk about safety, depending on what the issue is, that may be social and built environment, that may be, or neighborhood and built environment, or it could be social and community context. So I would offer for you all to think about, if it wasn't listed on the PowerPoint slide or you don't see it otherwise, what is the spirit of that social determinant of health element? And then feel free to add other things, if you will, to that. I mean, the benefit of using that framework is that's a framework that's already in play within HHS, other parts of the department, other activities. And so again, with my eye of seeing how I want to use this in the future, I'm not giving some people a new framework to then figure out how it fits with everything else the department's already using. I'm giving them tools and resources in an existing, known, approved, agreed upon framework, which I think will greatly enhance our ability to be successful in implementation. And I think, did I get all of them or did I miss? I think I may have missed one.
I just talked about the structural determinants of health that go above HHS, like Congress actually funding IHS and this sort of thing. Yeah. So are we able to come up with recommendations such as that?
Yes.
Thank you. That was very clear on your answers to very important questions. Camille.
Yeah, thank you. This is just following on Margaret's one of her comments, and Rear Admiral Collins, and your response to that, having to do with the spirit of the social determinants of health as articulated in the Healthy People's 2030 recommendations for health and well-being. So my question is more around whether we should be using the term health or the term well-being, or both of them. And the reason I'm asking that is it seems to me that the social determinants of health are really a description of all the things that have to work in concert for people to experience well-being. And so ultimately, well-being is sort of where we want to be headed. And well-being is something that when you talk to communities, and I work within communities, so you talk to communities, that is something that resonates with them. And they can, if we wanted this agenda to also have an element of, community activity and community contribution, I think it would be helpful to get some clarity on your thoughts about using that term well-being as we move ahead.
So that's very interesting. So I hadn't thought of that. And I'm sure, you know, health, my use of health absolutely is a bias of where I sit in my training and in clinical experiences. But as you're saying it out loud, absolutely. I mean, all of the health, the community context, the education, the neighborhood, economic, all of that contributes to health, right? But it also has a broader impact on well-being overall. So I'll say I'm not opposed to a focus that from a well-being perspective. I do hear what you're saying in terms of if that's a perspective that would be better understood, embraced by communities, because they have a role too in all of this. In some form or fashion, that would be something that I would consider. I don't know if I answered that well, but I do think I liked, we haven't talked about, I think I did mention one part about infrastructure and community engagement, because I had to get the community in there somewhere, but that didn't really do justice to the importance of community engagement and community involvement. And so if it would be ideal to use terms that can support community engagement and involvement in addition to the work of federal government, state government, territories, tribes, community-based organizations, and everybody else.
Great, thank you so much. I appreciate that clarification, thank you.
With that, we're gonna bring this to a close. This has been just incredibly helpful, and I'm sure we could go on. But with that, I'd like to thank our guests, Rear Admiral Collins, but also our amazing committee for their terrific questions and everyone who tuned in today. The conversation will continue. So we appreciate the activity on the Q&A, and we welcome all comments and questions. You can send those to Amy Geller, and I'll put the email if you have additional questions. Amy's our study director. So please keep in mind that any material you wish to share with the committee will be made public through the project's public access file. This process is in place because the National Academies comply with Section 15 of the Federal Advisory Committee Act. With that formal statement, this meeting is now adjourned. And for committee members, we will be reconvening in a closed session at 2 p.m. So we'll see you then. And thank you again, Rear Admiral Collins.
Thank you so much, everyone.
Thank you, Dr. Collins.